And good morning, everyone. Great to be here. I was invited to give this talk. I think it was last week. So very excited to have this opportunity. I'm postdoc in the department working with Professor Lucy Kluver, and in the Accelerate Hub, which works on identifying sort of cost-effective interventions or estimating the cost-effective interventions for adolescents across Africa. So that started in 2019, and we're sort of coming to the end of that phase of funding. And so it's interesting to see how some of that work has sort of led to where we are now. And hopefully I'll be able to sort of draw some of the threads between that work in this presentation. So as I mentioned, as a team, the Accelerate Hub aims to generate evidence to improve adolescent well-being, and key kind of areas of focus are health, education, and violence prevention. And this is really to help governments achieve the SDGs at scale. So the focus is finding effective and cost-effective ways for supporting governments to do that, and also recognizing increasingly the multiple crises that adolescents face. So a sort of direction for the future is ensuring that services are adaptive to crises. And importantly, as part of the work that we do as well, is also engaging adolescents in this in the process of generating evidence-based policy making. So there are various teams, and the team is split across the department and the University of Cape Town in South Africa. But those involved in this particular project are on here. So it's a sort of large team that have kind of all been doing a huge amount of work to sort of bring together different pieces of evidence for us to be able to kind of build some of the results or findings that I'll show later in the presentation. So just to acknowledge all of the work that's gone into this. So around last year, UNICEF made a commitment for bold and transformative change towards a more gender equal world. This is sort of a cross-cutting area for them. And they published the Adolescent Girls Strategy, which makes a case to support a large number of girls globally to support outcomes across education, health, and violence prevention. In this strategy, a significant economic benefits are expected from investments in this area across education, health and nutrition, child protection, and economic empowerment and innovation. In July last year, a UNICEF Goodwill Ambassador at a conference in Rwanda called for $1 billion to be invested to improve girls' access to social and health services. So when we saw this, we sort of at the similar time to when we saw this, we were contacted in one of the calls that we were having with the UNICEF gender team. They asked, were interested in trying to estimate the return that this type of investment could bring. An investment of this size could bring for adolescent girls. And so we sort of took on this challenge, and based on some of kind of our previous work, said that why don't we give this a go? Now, sort of no parameters were put around this $1 billion, and actually, in terms of sort of large-scale investments, $1 billion isn't actually a huge amount of money. So that was kind of what we were working with. So in terms of kind of where the existing evidence is around economic modeling and kind of returns on investment, recently, in sort of last 10 years, there has been a real growth in sort of trying to estimate returns or savings associated with reducing certain adverse outcomes for girls. But often these don't include very much detail or any detail on what interventions would be used to achieve said goals. So an analysis might set out by saying that if SDG goals were achieved, what would be the savings in that area? And generally, whilst these are incredibly helpful for advocacy and for sort of generating political will and interest in certain areas, they don't necessarily provide much insight into which interventions would be able to achieve these policy goals. There have also been several large-scale analyses of returns on investment with certain intervention scenarios. Kind of the Peter Sheehan et al. Paper in 2017, which sort of built a case for global investment in the capabilities of adolescents. Really interesting paper, and very comprehensive. And there was also Plan International, in collaboration with the City Investment Group, put together a case for holistic investments in girls to estimate the returns on investing in girls' education. In these two cases, both analyses are incredibly useful, but the detail on exactly which proposed interventions is sometimes vague. In the case of the Plan International and the City analysis, all the proposed intervention scenarios are incredibly ambitious. So in the case of the Sheehan et al. Paper, which is a global investment case, they call for huge investment across a number of areas for transformative change, which often governments aren't in a position to be able to put forward that amount of investment straight away. So again, so that sort of as a point in case, when we dissect the Sheehan et al. Paper, so in terms of global investment, this analysis evaluates the return from investment from 76 interventions across multiple sectors. And alone, the health sector interventions per country per year would be worth a 22.4 billion investment. And you can see there in the pie chart the different areas. And sorry, some of the text, when I loaded it onto this computer, the text size changed. So marriage, IPV is hiding underneath marriage. You can see the different areas that those 76 interventions are concentrated across. So large number of interventions in maternal and child health and sexual and reproductive health and rights and HIV/AIDS, and fewer interventions across those other areas. So I suppose that kind of leads on to thinking about, well, what about an alternative approach? What if we were to start with a more manageable step forward, where we didn't necessarily ask governments to scale up investments in 76 interventions? What if we were to start by saying, and we could identify an evidence-based and simple package of interventions that would be able to impact on multiple outcomes and that would represent a more realistic kind of short-term step forward? And I suppose at that point, it's not to say that if governments do want to achieve transformative change for adolescents, then investing in 76 interventions across those areas would be necessary. But all that we're really saying is that within the scope of what might be achievable, what would be an alternative scenario, and what returns would that bring? So when after deciding that, then the next stage was to say, okay, well, rather than trying to focus across countries, why don't we focus on one country where there has been strong commitment to adolescent investment, and there is a good evidence base. So before deciding on which country to focus on, we sort of needed to think a little bit about which interventions would be suggesting. And this is where all the work that we've been doing as a hub since 2019 sort of comes in. So the hub, there's a wide variety of different work that is ongoing at the hub, and I'd really recommend looking on the website to have a sort of closer look at what is going on. But one area has been a sort of concerted effort to sort of around observational analyses. We're using observational data to identify candidate targets that would have for interventions that would have cascading effects across multiple outcomes. And when we've sort of pulled all of that evidence together, so this includes at the moment 12 analyses of what we are coining their adolescent accelerators, being sort of protective factors or for adolescents that have impacts on multiple areas of their lives. There are several areas that sort of really stand out. Parenting support, or there it's called parenting support, or what might inform an evidence-based package of interventions. Sort of what the actual measures that we've had used to sort of inform that would be things like parental monitoring and supervision and positive parenting scales. But in that those indicators have been associated with lower violence victimization in 13 out of 18 tested associations. Cash transfers or improved or higher food security have been associated with better educational outcomes and better SRHR outcomes in multiple analyses. And perhaps where we have less evidence, sexual and reproductive health and rights services or kind of contact with community health workers we found to be associated with lower rates of early pregnancy, child marriage, and better education outcomes in a single study in Ethiopia. So this is kind of when we've looked across the different studies, these are the three areas that have really sort of stood out to us as candidate areas for investment. And when we sort of look through the kind of framework for investment or sort of gender responsive outcomes, if we extract what those observational analyses and sort of generalize those to what interventions would be able to act on those protective factors, then we can see that actually those types of many of those those types of intervention that we would be recommending would have gender responsive impacts across economic security, improved health, enhanced education, and increased protection. So so that was how we sort of arrived at that was much of the motivation for why for the interventions that we would focus on in this investment case. In terms of which country to focus on, as mentioned, we wanted to focus in a country that had recent commitment to promote adolescent well-being, and also sufficient data and a social and healthcare sector that we could sort of model a scale up of. So in Kenya sort of really became the focus of this. And in terms of recent policy strategies, standards, guidelines, and laws and acts around sexual and reproductive health, Kenya has enacted a number of policies and strategies in this area, and also has standards and guidelines for health services directed towards adolescents and youth. In terms of access to education, in 2008, secondary education was made free, and there is also a national social protection policy. And in terms of violence prevention, in 2019, the government published a national prevention plan on violence against children in Kenya, and in 2022, a Children's Act was passed repealing common law's right to punish children. So what we have is a situation where our motivation for the investment cases is around three sort of intervention areas. around sexual and reproductive health, economic support to support access to education, and parenting or sort of parenting support to improve parenting at home to reduce violence. In terms of the status of key adolescent and youth outcomes in Kenya, in general, Kenya has sort of higher than average for the region indicators for across these areas, but many are still, but there are still a sort of much progress kind of needed in these areas. The incidence of HIV is still very high and predominantly amongst adolescent girls. So adolescent girls experience rates around 3 times higher than adolescent boys. There's still great unmet need for contraception, and rates of child marriage and teenage pregnancy remain high. And you can kind of see that that also the rates of violence victimization and out of school also remain high amongst adolescents. So when we so the next step was for us to sort of look at the barriers faced by adolescents and youth in Kenya and just check that some of the interventions that we were proposing, the 3 interventions that we were proposing, would actually overcome some of the barriers that are faced by adolescents and youth in Kenya. For example, we wouldn't want to be suggesting, drawing from our observational evidence and then applying that in Kenya, or if the situation was actually that there weren't enough health facilities, if that was the supply side issue rather than well, that's a bad example, but if access to schools, secondary schools, if the actual facilities was an issue, then we wouldn't necessarily be wanting to propose cash transfers, which is aimed at defraying educational kind of costs. So in terms of the barriers faced by adolescents accessing health services, these can be split across the demand side and supply side. So on the demand side, most studies point to myths on family planning, especially around long-acting reversible contraceptives and the side effects that those have. Another points to gender inequality, so girls' ability to negotiate safe sex. And then also, and thirdly, a lack of knowledge on where to obtain contraceptives. On the supply side, the main barriers are around staff attitudes and discrimination of adolescents. So the way that health care staff or providers interact with adolescents. Lack of privacy for adolescents when accessing health services. So generally, adolescents don't necessarily, where there are kind of a social stigma around sexual debut, and adolescents don't necessarily want to be seen to be accessing sexual and reproductive health services. And then generally a lack of guidelines linked to that on packages of care to offer adolescents. So they sort of fall in this grey area in Kenya specifically, where there's still sort of some policies say that in order to that adolescents need parents' consent to access contraception, and there is a sort of gradual move away from that. But the policies are still there, and healthcare providers don't necessarily know where they fall when trying to provide contraceptives to adolescents. In terms of accessing secondary education, in spite of it being free, there are still several significant costs that are incurred trying to access education. So things like the cost of uniforms, transportation to and from secondary schools, books and learning materials. And in Kenya, generally, although the policy to introduce free secondary or kind of remove secondary school fees, many schools still charge parents a motivation fee in order for children to access that school. and just that's despite it being illegal and the government trying to kind of crack down on that. Then there is also the distance to school, which is in some cases an issue. In terms of accessing social protection, a main kind of barrier there is is budgetary constraints. So there has, and I'll point to slides later in the presentation around this. Since sort of between 2007 and 2018, there was a sort of consistent increase in investment in around social protection, but that's recently dropped off, and there has actually been a reduction in the number of children that are being supported through the social protection system. So we know that we have our observational evidence and the kind of situation in Kenya has pointed to three intervention areas, and we've sort of looked and seen that that those intervention areas would respond to some of the priority barriers that are faced by adolescents in Kenya. But even then, and I think that this is a really interesting sort of conundrum which you face when trying to generalize evidence to actual action in a country, which is that we might have evidence to support an action, but what should we actually do there on the ground, or what should the government kind of, how does the evidence from the interventions link to existing policies and some of the decisions that would be feasible for governments to take forward? As kind of linking back to the observational evidence that I showed, one of the areas that we had least evidence around was the sexual and reproductive health and rights. We only had one study. It was from Ethiopia. And we weren't totally sure about, we couldn't, even when we were talking to UNICEF and we were talking to other colleagues, what a specific adolescent sexual and reproductive health and rights intervention should look like if implemented across Kenya. It was difficult to get recommendations around this. So we went back to the literature and ran an overview of published reviews using a kind of standard approach with a keyword search, and complementing that with key informant interviews with researchers and policymakers in Kenya to sort of identify what an adolescent youth sort of sexual and reproductive health and rights intervention might look like within Kenya. Through that, as we sort of brought together all of those different reviews that we found, we found 16 systematic reviews in this area. So there is a sort of strong amount of evidence, amount of research in this area globally. That brought back 139 articles within East and Southern Africa. And after reviewing that, sort of the full text, those full text of 96 articles that after screening for abstracts, 9 articles could be included would sort of support what an adolescent sexual and reproductive health intervention might look like in this area. 3 of those studies were in Kenya. We also did the same for cash transfers and parenting support. Luckily for cash transfers, UNICEF recently published a sort of comprehensive review of non-contributory social protection and adolescents. So we were able to sort of dive into that and complement with follow-up searches of more recent evidence. So that identified 16 evaluations, 7 of which were in Kenya. And in terms of the parenting support, work done actually in this department had brought together all of the sort of global evidence around parenting support programs, which we were able to use to identify studies in the region too, And we ended up including 8 articles, one of which was in Kenya. So this evidence has been incredibly. This is sort of the basis for the evidence base that we've used to sort of fine-tune the specific interventions that we would be recommending, and also identify estimates of the expected impact that interventions would have if for beneficiaries in Kenya. So when we bring together that that information, that can sort of be organized in as it is on this slide. So youth-friendly health services, and I've included here the little numbers next to the relevant outcomes. On the right-hand side in the bottom corner, it gives you an idea of where that evidence is coming from. Adolescent youth, generally what the evidence pointed towards was, as we reviewed it, there were sort of two main forms of effective sexual and reproductive health rights interventions that came out of the literature. One would be school-based comprehensive sexual education, and the other would be a sort of multi-component intervention that aims to improve health services and also provide peer-to-peer or some community-based education for adolescents in that area. And you can kind of see for those multi-component interventions that they're acting both on demand and supply side. And the evidence is kind of basically very supportive of the latter type of more supportive of the latter kind of intervention, particularly in countries where there is stigma around sexual and reproductive health of adolescents, and where teachers may not necessarily be well equipped to provide comprehensive sexual education. So if focusing on just the adolescent youth-friendly health services that act on both supply and demand side, when we bring together that evidence, we can see that estimates, the evaluations would suggest that this type of intervention would improve monthly visits to clinics, use of long-acting reversible contraceptives, improve HIV testing, and improve condom use, both consistent condom use and at last sex. Kenya's cash transfer program, which is the cash transfer for orphans and vulnerable children, is one of the sort of it was one of the first to sort of be rigorously evaluated in a sort of by a project called the Transfer Project, which latterly sort of ended up running and continues to run evaluations of cash transfers across countries in Africa. And so a large number of studies are published on this program. And this program would be expected to, has been found to have impacts across reducing adolescent teen pregnancy, reducing depressive symptoms, participation in home farm labor, and improving school enrollment and reducing sexual or delaying sexual debut. Now, importantly, we both looked for, kind of as is on this slide, we both looked for overall effects and also tried to see whether it was possible to sort of, whether studies had disaggregated those effects by gender, as that was an interest of ours for to sort of focus on later on in some of our modelling. And you can see that sometimes evaluations show impacts for boys, but not for girls, or the reverse. The last intervention around parenting support. So this is based on evidence also largely generated through this department, has impacts across a number of different areas, primarily around physical and emotional abuse, school and reducing school violence victimizations in girls, and also other areas including depression, alcohol and substance use, improved sexual health communication from parents to girls, and reduced household financial insecurity. Interestingly, in Tanzania, results show that caregiver support for education actually decreased as a result of the program. So, this is basically where we're getting closer. To what these interventions might look like, and we're confirming that they would have multiple impacts for adolescents. So I suppose then the next decision was to decide on which parameters to include for the modeling for our modeling scenarios. So whilst these estimates from these evaluations provide a kind of snapshot of what impact might be expected, generally when in analyses such as investment cases, it's usual or common to try and project over time, because if by only estimating the return on investment in a single year, then you're likely to massively underestimate the cost effectiveness of an intervention, which might have impacts for a longer time period. But acknowledging here that the parameters that you do include in a modeling scenario are subjective, and Amartya Sen's written quite a lot on this, that it's possible to, this is very much defined by the analyst, and so important to be transparent about it. So to then take some of that evidence and try to generate estimates of the return on investment of this type of intervention, we took a sort of standard time horizon. We've decided to take a standard time horizon of around 10 years. So that includes both implementation of programs, and also I suppose now it's important to say that this is very much work in progress, and so some of these parameters are still sort of being decided upon, but we're still undecided on whether or not we will sort of. Well, I suppose actually no, that's not true. So and the impact will be of the time horizon of the impact will be over lifetime, because we do actually estimate productivity returns. The scenarios that we would be modeling are no change to current status of social and healthcare interventions. And secondly, national scale up of the 3 programs that I've presented on in previous slides: adolescent youth-friendly health services, expanded coverage of cash transfers, and targeted scale up of parenting support program. And I'm going to get into a bit more detail of what that would look like in the next slides. The methods that we would use for valuing benefits are around sexual and reproductive health, are number of averted cases of HIV and averted teenage pregnancies. Around for education would be completed years of secondary school, and around violence prevention, number of averted cases of emotional and physical abuse. This is a sort of in a phase 1, and ideally we would then scale this up to consider other outcomes. The methods for estimating costs are all estimated from the provider perspective, and based on program costing reports that we've then estimated unit costs and then scaled those to the modeled interventions. So what are the actual interventions that we're proposing going to look like? So sort of after reviewing all of that evidence, the most commonly and type of intervention that would have and most effective intervention for scaling up adolescent youth-friendly health services looks like And I've organized all of these into intervention inputs, outputs, and outcomes, just to help sort of process what would be included. So this intervention would include components to train healthcare providers in adolescent, youth-friendly, and sexual and reproductive health right fundamentals, value clarification and attitude transformation and guidance on upholding confidentiality, improve healthcare facilities to ensure privacy and publicity for adolescents and youth to increase use. And also to train peer providers to provide community-based peer-to-peer education. So in order to do this at scale, it would require around 100, we estimate, based on resourcing from previous evaluations, that it would require around 100 national trainers. And then kind of based on Kenya's administrative levels, it would require 879 ward trainers, which are sort of similar to a lower level of disaggregation than, or I'm trying to think what the equivalent, I'll have to come back to that. And then it would require sort of 1,328 field supervisors in field to sort of supervise the peer providers. These inputs would then result in the training of around 5,000 healthcare providers, the improvement of around 2,000 healthcare facilities, and training of around 15,000 peer providers. So it's about a third. Yeah. Yeah. And what we've done actually, so I'd need to actually double check that. But basically what we've done is, you can see that, so the resourcing is based on from other studies. And what we've tried to do is triangulate what the resourcing was in those studies, when we scale it, how that would then compare proportionally to the healthcare cadre in Kenya. And this does represent a realistic proportion of that, but the exact proportion, I can get that for you. As kind of the focus of so in terms of the outcomes, and in this first phase, we're focusing on improvements, and we would see improvements in consistent condom use amongst girls, but no change for boys. We would see increased use of modern contraception amongst girls, but no change for boys. And that's based on the evidence on the reviews that I presented earlier. So the proposed cash transfer intervention is expanded coverage of the existing cash transfer for orphans and vulnerable children program. So the intervention, I suppose, could be considered as an increased budget for the program to support eligible households. And the eligibility criteria there underneath the intervention. The inputs are really budget for program administration, and then the actual value of the cash transfers that would be provided to new beneficiaries, which are around $23 bi-monthly. Based on what we've this sort of to provide a bit of an insight into how kind of some of these numbers are generated, what we've done is, or Reith has done, is to track the increase in coverage from 2007 to 2018, and generate a sort of to look at what the annual scale up of the program has been in the past during growth periods, and then to model that over the next 10 years. And so based on investment, we would expect that over 10 years, the program could reach around 1 million new beneficiaries. And that would improve rates of grade transition for both adolescents, girls and boys by 5% in secondary school. So the third intervention is parenting support. And so here, this is a more targeted scale up of parenting support. The intervention can be considered as training facilitators to deliver a 12-session parenting support program modeled on the Parenting for Lifelong Health intervention that aims to increase parenting skills, positive parenting, and decreasing harsh discipline. Based on resourcing in Tanzania at scale, and the original randomized control trial in South Africa, the necessary inputs at scale are kind of listed there in the table. And over 5 years, which is currently the program would be expected to reach 50,000 adolescent parent dyads. And again, similarly to what we've done in for the cash transfer program, that the reach or the coverage of the expected coverage of the program is modeled based on growth of a parenting support program at scale in Tanzania. Although sort of these numbers are still very much in flux and may change, as you can kind of see there, that a decision needs to be made around whether or not to use an average annual increase, or whether or not when once it's achieved scale, these programs can actually reach a large number of people in a single year. So in the graph in the bottom right, you can see that in 2020 the intervention in Tanzania reached around 28,000 adolescents. And so the other thing to say is that the parenting intervention in Tanzania would have a sort of concerted focus on gender transformative approaches, and also SRHR and HIV prevention as a kind of been trialed. I suppose then I'm kind of moving a little bit more quickly. What this aims as, based on the kind of proposed scale up, this is aimed at sort of a direction towards sort of personalized social and healthcare, where all adolescents would be provided with sexual and reproductive health services. Adolescents in poverty would have better access to cash transfers. Adolescents in poverty and at risk of violence would receive all three of those interventions, and with sort of an increasing complexity of need as you move towards the top of the pyramid. This is what I've presented is really kind of where we are up until now. We have preliminary kind of cost estimates, and we do have preliminary estimates of impact, which I'm not going to show today because they are so preliminary. But this is the sort of the examples of how we then kind of cost what the proposed interventions would look like, and generate estimates. So there's often I don't know whether you can see this. There's often issues around kind of how we take evidence from trials and then generalize that to country settings. So, for example, the supervision and monitoring specifically for the adolescent youth-friendly health services is a problem, because often NGOs will budget huge numbers for their staff to be able to travel to counties or to locations to be able to supervise trials, and then we have to, so it's difficult to then use that data, and we have to use local estimates, which we're in the process of finalizing. Similarly, the same process has been done for parenting support and cash transfers, although I haven't got the data to show for that. And so then this is what the proposed analytical framework for the actually incorporating combination impacts, which we haven't yet done, of different interventions. So really, where we have the strongest evidence for overlapping effects is between cash transfers and youth-friendly health services. So with cash transfers, delaying sexual debut, and youth-friendly health services, improving or averting cases of HIV and teenage pregnancy. So this provides a kind of overview of what the actual modeling framework will look like. Then the current process is to try and integrate what the knock-on effects of some of these outcomes would be on education, and also to think about how to include what the impact of better education might be on child marriage. There are also other impacts that we're not considering, we haven't been able to consider, and that do also sort of that would indicate that estimates that we do produce would be an underestimate of the cost effectiveness or return on investment of these interventions. So it's just to be wary of that. In terms of the actual modeling tools that we're using, the WHO Choice group One Health tool that's publicly available online has a very user-friendly tool for estimating long-term impacts of interventions on cases of HIV or HIV incidents. And also in the same tool is the FAMPlan modeling software, where you can model the knock-on effects of increased contraceptive use on fertility rates. We are developing our own kind of transition model for violence prevention. We have developed a decision model, but we want to improve that to also capture age effects. And we also have a secondary school grade attainment education transition model that we're using. Lastly, I guess is to just point to the work that Hernando has been leading in the department, which is also to try and discount the impact of interventions on multiple outcomes, which we would also be using here. And this example gives, but these are his slides, and I think he presented on this last term. So just to give an idea of how this works, the difference between buying 10 shirts with $200 with a cost effectiveness ratio of $20 per shirt. But if you were to buy 10 shirts and get 20 shoes free, then how do you estimate the cost effect, or the sort of the value of each individual shirt? Then it's necessary to discount for the additional shoe or the shoes that you also get when you spend that money. So in terms of kind of a summary of current findings, this is kind of where we are at the moment. In terms of kind of, I suppose that the hardest part has been actually defining what the interventions would look like, and what they would include, and then sort of here's a summary of some of the next steps. So there's a lot in those slides, so happy to take questions and clarify wherever there was any uncertainty.